right? So this is now stage 5 of CKD. I'm on page 1570. So a patient reaches stage 5, which if you remember last week, this is a GFR of less than 15 liters per minute. So patient now has, is it still enough to sustain life? No. So the patient will die unless we place them on renal replacement therapy, which is a fancy word for dialysis. Okay. So the patient now has stage 5. So manifestations will be, of course, which phase of AKI? Is it the oliguric or the diuretic phase? Stage 5 of CKD. Which will it be similar to? The oliguric phase of AKI or the diuretic phase of AKI? The oliguric. The difference is, unlike in AKI, is the patient, can the patient in AKI oliguric phase recover? Yes. However, this here, CKD, stage 5, can the patient recover? No. So the patient automatically is offered a chance to be on the transplant list, meaning doesn't guarantee they'll get a transplant, but it will be offered automatically. Okay, so they'll be placed on the transplant list. As you know, it's not a guarantee, okay, unless you have a lot of money. Although they never advertise that. But of course, history tells us that we know Alonzo Mourning got the transplant, right? And so did other celebrities, or Selena Gomez, for instance, from lupus. She got lupus, she damaged her kidney, that lupus damaged her kidney, she needed a transplant. She suddenly got a transplant, right? Whereas we have millions of people on the transplant list, they have been for decades, they never get any, all right? So there, it helps, okay, if you have money, all right? The rest of us who don't have that much, then we'll wait in line, all right? So the patient now is in, again, in a permanent state of oliguria. Patient stays in that stage, and because of that, now they need and require renal replacement therapy. We will have to use either a machine or their peritoneal cavity as a replacement for renal function. Manifestations, of course, I won't repeat. This is the, imagine the oliguric phase of CKD, wherein the patient has hyperkalemia, hypervolemia, high blood pressure, uremia, right? So there's high BUN creatinine, waste products accumulate. Patient is in chronic metabolic acidosis. The patient has fracture susceptibility because of calcium disturbances. The patient has anemia, chronic anemia because of there's no more erythropoietin, among other problems. Depending again, also remember, did the patient just develop CKD or were there underlying conditions that led to it? There are underlying conditions. So on top of the CKD, the patient also is dealing with whatever caused their CKD in the first place. Okay, that could be diabetes and or heart failure and or liver or other metabolic conditions. Okay, could also be drug induced. So these are the problems now. So we've got sodium and water retention, which puts them at risk for heart failure and pulmonary edema. I already mentioned metabolic acidosis forever, anemia also mentioned, and fracture susceptibility because of calcium and phosphorus imbalances. So here's a summary of your manifestations in ESKD. The pruritus mentioned here on the skin is because of, especially in between dialysis sessions, because most patients don't get dialysis every day. They'll get it hemodialysis. I mean, they won't get hemodialysis daily, so it'll be every other day. In between the hemodialysis days, the patient's body tries to eliminate the waste products through the skin. And we call that uremic frost. They will have white powder on the skin, which causes it to be dry and itchy. So there will be pruritus. Okay, so I won't read the whole chart for you. So we just have the summary on the paragraphs, but the detailed summary is on chart 48-6. And complications, therefore, would include, and since they have anemia, then they will require repetitive or multiple blood transfusions. So every few months, they will require a transfusion. And of course, when that happens, one of those transfusions may cause a serious enough reaction, causing death, or they could, although rare, may sustain a infectious disease from one or more of those blood transfusions. An option or alternative to, let's say, the patient has Jehovah's Witness, then alternative to that would be erythropoietin injections. I had one drug on the quiz today, which was darbepoetin. So that's another generic name, but they're the same. They're all epoetin alpha drugs. Bone disease, as already mentioned earlier, patient will be prone to fractures as a result. Hyperkalemia is the most serious complication and may be a reason for frequent hospital readmissions, emergency readmissions. Some patients also, especially after decades of hemodialysis, will, of course, become weary, right? They'll grow tired of the whole setup, waiting for a transplant. So they'll miss one or two hemodialysis sessions. And the reason for admission from that decision would be, of course, hyperkalemia, or if not hypertension, severe hypertension. The pericarditis, pericardial effusion, these are all resulting from the waste products and of course from fluid overload, although they're not very common. So management, of course, will be symptomatically managing the complications, meaning you will give blood transfusions, give drugs, okay, specifically calcium and phosphorus, okay, supplements. Drugs too, we already have, and I had some questions again on today's quiz about treatment for hyperkalemia. Blood pressure medications, including diuretics. Now, the main treatment for ESKD, of course, is dialysis. That's what we'll discuss today. What are the options? Okay, what are the patient's choices on the type of dialysis that they will be using? That, of course, will be discussed between the patient and their physician. Goal of management is to, of course, provide renal replacement therapy, no matter how long, and again, the patient will decide. Okay, can the patient suddenly say they don't want dialysis anymore? Absolutely, yeah. We have a law. We have the right to self-determination. If they wish to terminate dialysis, say they're tired of it, they'll change their code status from full code to now a DNR, for instance, and then we'll have to respect that.
So
Yes.
When they stop with the dialysis, do they prep them for what's gonna come next? Like,
Yes, of course, before they came to that discussion, I mean, that decision, right, so there will be discussion among the providers, the patient's primary care physician, the patient's nephrologist, and they'll call in the palliative team as well. Palliative care is, of course, symptomatic treatment, including end-of-life care. So they'll be all part of the decision making. That same day, the patient will be seen by all of those I mentioned, and making sure the patient is aware of their decision. So a psychiatrist will also be called just to determine, is the patient making the right decisions, or is this some, because they have to rule out that maybe the patient's saying this as a result of metabolic acidosis, which does cause poor judgment and altered mental status. So they have to verify first that the patient understands, okay? And provider that will make that determination, of course, is the psychiatrist. But once the patient signs the documents, I mean, they can revoke it anytime, but unless otherwise proven that the patient is incompetent, we'll have to respect that decision. I read on the news today on the train, there was a Ecuadorian lady in Spain who was a Jehovah's Witness, and she underwent emergency surgery. And it's a general rule worldwide that during emergency situations we forego consent. Okay, we do away with consent because it's an emergency situation. Okay, so the assumption is Good Samaritan, right? That the patient needs help, so we will do everything. However, the patient did discuss it beforehand when she was still awake, fully conscious, that she did not want any blood transfusions. But because of the emergency nature and the surgery, she required 3 blood transfusions. So she went to court, although the doctors, surgeons had noble intentions to save her life. He still sued the hospital because they violated her rights. Yeah. So just a warning, so sometimes we impose our will on others, okay, on certain things like abortion, including blood transfusions. Okay, so just be aware that we do have laws, okay, and laws aren't always ethical. So just understand that. All right. So you may be placed in those scenarios. Plus, you're part of the team, so you'll be named in the lawsuit if this happen. Okay, so it's not just the doctor. You're part of the lawsuit as well. Okay, because that's your patient, and that occurred on your shift, on your watch. So just FYI. Okay, not saying that happens a lot. Okay, but maybe called. Don't worry, it's not against you. It's always against your insurance company, malpractice. Okay, so that's why you should carry malpractice insurance. Okay, they should be up to date all the time, so they have someone to go after, right? Otherwise, you'll be working for free. We have a summary of drugs as well. So this these drugs that we're looking at will be in the table. Blood pressure medications, there'll be a ton. So because of this list, look at it, the erythropoietin, and then we've got nutritional therapy as well. So these patients will have long list of medications on the MAR. I mean, a minimum of 10 up to 20 or even more, right? That's how many drugs. This is just for ESKD. Remember, these patients also had conditions, right? So if they're diabetic, you'll have a whole set of medications. If they have lupus that caused the ESKD, then they'll have a set of medications for lupus as well, etc. All right. Half ask any dialysis nurse. Half of the patients on dialysis are diabetics. So used to be during my time, half of them were hypertensives because we didn't have that many diabetics during that time. But today, half of them are diabetics. So if you're looking for a nice, stable, routine job, might want to consider hemodialysis. It's nice, steady, good money, flexible, you can travel, right? It's a good, Dr. Masi, Dr. Arif.
Yes.
Yeah, he was a dialysis nurse most of his career. So for nutritional therapy, of course, the dietitian will determine how much protein, because remember what is the consequence of protein? Where did BUN come from? protein metabolism. Okay, so we have to control the amount of protein with each meal. Yes.
So is it low protein during AKI, but then high protein?
It really depends on the patient's BUN and creatinine levels. It's not really on which stage. So the doctor looks at the daily BUN creatinine and makes changes on the order if necessary. But definitely we'll have to control the protein intake. Okay, how much? That really depends on the BUN and creatinine. So this is the recommendation, 1.2 to 1.3 grams per kilogram per day. And for fluid allowance, like I mentioned last week, the basis for the fluid restriction is usually the urine output yesterday plus insensible fluid loss. So if the patient, what is this patient's fluid status again? Are they in a diuretic or the oligoric phase? Oligoric phase for how long?
So
Forever. Okay, this is ESKD. They'll be in the oligoric phase forever. So 400 ml or less, right? Or sometimes they will be anuric, which is less than 100 ml per day. So if they're anuric, of course, that will restrict the fluids even more. If they're oligoric, then of course, the assumption is the patient has 400 or less, right? Plus insensible fluid loss. So they add about 600 or 900, depending on the nephrologist. So most people are on a 1,000, sometimes 1.2 liters, they have a little allowance, while some have 800, or really anuric patients, they have about 500 ml per day. Plus, remember, 500 ml, that's a bottle, right? Yes, a small bottle. And that's for the whole day. So you have to divide that from the moment they wake up until bedtime. And that's your decision. Okay, how to allocate that, because you have med pass, they can't swallow pills without liquids, can they? And that includes all liquids, okay, because you have liquids during the meal and then you have free water in between meals and snacks. So here's dialysis now. So the patient and the physician will discuss what is the most appropriate dialysis method to fit the patient's lifestyle. Okay, so of course, this will make a difference if the patient is still working versus retired, or if this patient travels a lot, or if they're bedbound or homebound. I have fellow workers. We have one CNA currently in our facility that is on dialysis. Okay, so you still can hold a job while being on dialysis. Doesn't have to stop you. You don't have to go on disability just because you're on dialysis. Okay, so it's up to you. Although you have that choice. Okay, you have the choice to go on disability. You're on hemodialysis, but you don't have to. Because of course that's a decision. If you go on disability, then that means you're limited in your income, right? You're on a fixed income now. What if you still have a mortgage? What are you gonna do? Right? So some people have no choice. They have to keep working. So our discussion here will focus on what are your responsibilities when the patient is on dialysis. Depends really on, well, what type of dialysis is the patient having. Okay. Now the patient has to understand, and this is your job to reinforce. We're not the ones really making the first education. It's usually the nephrologist that will explain. However, will the patient fully understand that with that one discussion? No. So you have to reinforce the teaching. So here is where you come in. So we have therefore to understand how does each dialysis method work so that you can be effective in your reinforcement of the education. First of all, we need a access device. Depends again on what type of dialysis you'll have. Next is how often it will be done. What are the expectations? Okay, how long will each method last? What are needed? And of course, problems to report. Now, the problems to report here are usually the manifestations that got worse. So let's say we know the patient is in fluid overload, but is it expected that they will be in heart failure? Or is heart failure a complication? I repeat, is heart failure a manifestation of CKD or ESKD, or is it a complication? It's a complication, of course, right? So you have to distinguish between what are expected, meaning, will these patients ever be having normal? Probably not, right? However, since they have abnormal findings, are all of them necessarily reportable? No, because they are expected given their diagnosis, right? However, doesn't mean we don't report complications, such as one example is heart failure. Patient is already in heart failure. Or we know they're in hyperkalemia, but are we worried about mild or severe hyperkalemia? We will be worried about severe. Okay, so these are again worsening of the conditions, then that would be something reportable. So here are 3 bullet points on what will be a part of your teachings on what the patient or the family will be reporting. Okay. Okay, let's go to RRT now. So this is renal replacement therapy. This is referring to dialysis. As described here, I'm on page 1577. Dialysis can be short-term or long-term. Remember, in AKI, can we do dialysis in AKI?
It's not
Absolutely not. I mean,
depends
we
on the
discussed that
sex.
with severe hyperkalemia, for instance, unresponsive to all the therapy. Can we do dialysis? Yes, so that would be short-term dialysis. Okay, but generally speaking, in ESKD, of course, this would be long-term, unless, of course, the patient gets a renal transplant. Then that's a different story, and they don't need dialysis. So what is dialysis? This is renal replacement therapy. So we're using another method to replace renal function. So that's either using a machine or using the peritoneum. So is dialysis only indicated in ESKD? No, we mentioned AKI also may require dialysis. Other acute conditions such as, let's say, you have acute poisoning. Okay, so severe poisoning. So the way to clean the poison out of your blood, let's say there is no antidote, is to dialyze you. Okay, so we'll use a machine, remove those toxins, whatever you ingested. Okay, so that's one reason. Or medication overdose. Okay, let's say the drug has no antidote. So how do we remove that drug from your toxic levels of drug from your body? Dialysis. Again, the decision to initiate dialysis has to be well discussed. Okay? The patient must understand the implications of whichever choice they make. They should understand also that there are complications both with going for dialysis or if they decide not to go for dialysis. Okay? There are always consequences of either decision. Transplant, we will discuss next semester under immunity. So we will not discuss it this term. Let's look at the first and most common method of dialysis, which is hemodialysis. So the description here is we're going to use a dialyzer. This is a machine with a synthetic semi-permeable membrane, and we will use dialysate, okay, to filter, to help clean the blood. And these are the mechanisms involved in the machine. There's diffusion, osmosis, and ultrafiltration. So similar to how the kidneys function. Okay, so they made a machine that will mimic the function of the kidney, although this will never replace the kidneys. Kidneys, of course, the kidneys can make erythropoietin, right? Obviously, the dialyzer can't give erythropoietin, so you have to give the epoietin alpha in subcutaneous injections instead. And the machine can only remove so much blood. I mean, so much fluid and waste products. Okay, unlike the kidneys, which again reinforces that this will never replace the kidneys exactly, but this is all we got. And this is the description of the system. So we have a machine. So in order to accomplish hemodialysis, we will need an IV access site. The IV access site can be a catheter. So remember last week when we discussed central lines? Okay, so this is the fifth type of central line. So as I described, this can either be non-tunneled or this can be a tunneled central line as well. It could be in the neck, jugular, could be in the femoral artery, or it could be in the subclavian artery. So that's one way to do it. This setup, of course, using a central line, is this an ideal IV access? We're going to be using this at least 3 times a week forever. So is a central line an ideal access? No, because what's again the one risky? Okay, so the patient will be at risk for infection. Okay, so it's not the best choice. However, if we should initiate dialysis, the patient may have to start with a central line first, okay, a hemodialysis catheter, either tunneled or non-tunneled. So here's the idea. We'll need 2 lumens on this catheter. Should we go for a central line? So there will be 2 lumens. One will remove blood from the patient's body. Blood goes to the machine, the dialyzer, and after it's being cleaned, it will return to the patient's body. And this will go on for anywhere from 1 to 3 to 4 hours. Usually maximum is about 6 hours. But most people go on dialysis for about 3 to 4 hours each session. And that's typically over 3 days a week, either Monday, Tuesday, Wednesday, or Tuesday, Thursday, Saturdays. We do have inpatient dialysis units that can handle emergencies. So if a patient comes in between dialysis days, needing emergency dialysis, so we have them in hospitals. Of course, outpatient dialysis centers, they're closed weekends. Okay? So they're only open on weekends if, let's say, they have a really high caseload and nurses are willing to do overtime. Okay? But of course, nobody says yes. Your only choice is the hospital, right? We won't discuss the dialyzers because you are not expected to be hemodialysis nurses out of fresh from graduation. So NCLEX will not ask you about the procedure. The questions on the NCLEX will be, of course, your responsibility before and after the patient undergoes dialysis, because you're the one sending the patient to dialysis and you're the ones receiving the patient after they undergo dialysis. Does that make sense? Okay. So your responsibilities will be on the medications, on watching for complications, both before and after the dialysis. Okay, let's look at the vascular access first and our responsibilities. So this is the rate. So if the blood is filtered at a rate of 300 to 500 ml per minute, what is your IV access? Should it be small or big? These are large vascular accesses, so that's why we require at least a central line. Okay, we can't do this through a peripheral line. So we have double lumen. Why two? Why not one? Okay, we have one has two, one lumen will remove and one lumen will return blood. Okay. So I already told you that it's either the jugular, femoral, or the subclavian. So here are the possible sites. So this picture here on the patient's right side, is this a tunneled or non-tunneled? Look at the setup. This is a tunneled catheter. Why'd you say it's tunneled? Well, you have two incisions here, right? So this is where it entered the patient's body, and this is where it entered the central vein. So this is a tunnel catheter. If it was a non-tunnel, then it would be closer. There's only one entry. Since this one has two, then that's a tunnel. What's the difference again? So what's the benefit of a tunnel? Can be used long-term and less likely to get infected. Another vascular access device which is preferred is a fistula, an AV fistula or an AV graft. What's the difference between the two? An AV fistula is a surgically created connection between an artery and a vein. The doctor will choose a suitable vessel. So before they do this procedure, this surgical procedure is they have to map the patient's arms. So they'll look at the forearm up to the upper arm on each arm and see which arteries and veins are most suitable for this procedure. So the objective is to create a large blood vessel. How do they create a large one? When we're born with these arteries and vein sizes, right? So when you put them together though, are arteries and veins made the same way? Are they the same structure? Which one is stronger, arteries or veins? Okay, so and which pressure is higher, arterial or venous? Okay, arterial have higher pressures because of the aorta, correct? All right. So once you connect both and expose, since now you connected an artery and a vein, creating one vessel, what will happen to the venous side of this new connection when you expose that vein to the same pressures on the artery? What will happen to that side? Not necessarily weaken, but will it enlarge? Yes, it will enlarge as a result because now you're exposing a low pressure vessel to higher pressure. So this will create over time, over the next several weeks, months, it will grow bigger and bigger. So now if you have a really big blood vessel, can you now stick it repeatedly? Yes, now a dialysis nurse can stick it with an 18 gauge needle repeatedly, okay, 3 times a week. Because it's so big now.
The big lumps and bumps.
Correct. All right. So it's so big now, you can't, two things, you can't miss it. I mean, how can you miss it? It's very big. So you put 2 needles in it repeatedly 3 times or more each week. Okay, of course, you stick a different part of it, okay, allowing that side to heal first, okay? You stick that part, then next week or next 2 days after you stick another part, okay? But you're sticking a really huge blood vessel repeatedly, and that big blood vessel can take it, okay? It's so big. Or if there's no suitable fistula blood vessels, then those resort to a graft. A graft, though, is made of silicone and is more ready to use because this fistula here, up here, the ideal vascular access, takes weeks, months, or sometimes even years to mature. So sometimes it doesn't mature, so it's not always ready for use. We have to wait for that fistula to mature and grow before we can use it. So if that's the case, then a graft may be an option. So the figure B is a graft. So you put a graft, which is a silicone catheter connected to a vein and a artery, and then you stick the graft. Okay, you don't stick the blood vessel, you stick the graft. So those are our options. So if we have either a graft or a fistula, what are your responsibilities? Okay, so we will have the responsibilities listed, but I'll tell you now. So do you want to abuse this
No, nothing.
this arm?
No blood pressure should be
Okay,
low.
so you should not injure or expose this arm to trauma. Okay, what are examples of trauma? Sticking it with needles, okay, for other purposes other than hemodialysis. Putting a blood pressure cuff over it. Letting the patient carry heavy objects with that arm, okay? Sleeping on that arm, okay? So you don't want it to be exposed to trauma. You want to take care of that arm, okay? Like it's your, your wife or your firstborn child, okay? Like, hey, how are you doing? Okay? So you're going to take care of it, love it, all right? Because you need it for survival. You need that every week, 3 times a week, forever. So here's the preferred permanent choice. Okay, so we prefer an AVF over a central line over a graft. Okay, so this is perfect. There's nothing artificial about this. Okay, so this is your own blood vessels. Okay, so this is typically about 3 months to mature, but sometimes, unfortunately, they may not mature. And once established, longest useful life. Okay. Sometimes they go bad, they get damaged, and then we can create another one. Okay, we can create another one on the same arm or on the opposite arm. And the graft, again, artificially created. So we have a synthetic graft, which is what we stick. So whether it's a fistula or a graft, your most frequent assessments would be, is it working? And in order to know that it's working is you carefully and regularly assess for a bruit and a thrill. What's the difference between a bruit and a thrill? Okay, very good. So bruit is a sound, so you listen for a bruit. A bruit is a gushing of blood over a large blood vessel. So it will sound like. Okay, so you put a stethoscope over the graft or the fistula and you will hear a bruit, or you will feel a thrill. Again, this is the vibration caused by gushing of blood through a very large blood vessel. Okay, so you always look for what 2 things again? Bruit and a thrill. You should document that every shift, at least once every shift. So here's a warning about fistulas and grafts. So failure of that access results in hospitalization because now the patient needs an implantation of a central line, okay, the hemodialysis catheter. Because how else will they get dialysis? Okay, so they have to be hospitalized for, for the doctors to insert a hemodialysis catheter. And with every patient admitted with a fistula or a graft, we put signs everywhere on the door, on the patient's wall, on the patient's chart that will say, No lab draws, IVs, or blood pressures on, and you will indicate left arm or right arm. So you have to communicate this, because otherwise, what will your CNAs or your nursing patient care techs do? They'll use that arm, okay? Because not all of them are aware, okay? Especially if the patient has dementia. It's good if the patient is alert and oriented because they'll tell you. Okay? They'll tell everybody. They're very protective about their dialysis access. So they'll say something. But what if the patient's unconscious or is lethargic, for instance, okay, which is usually the case when they come in, when they're hospitalized. So they can't tell you, and then, so unless there's a sign, nobody will know. And what will also help is, of course, the machine, especially if your hospital has a dedicated machine for each patient. Of course, where will you put the machine? The side opposite the graft or fistula. Okay, so if they have a graft or fistula on the left arm, where will you put the blood pressure machine? On the right. Okay, so that way, because are you likely to put it on the other arm when it's on this side? Yeah, automatically you put it on whichever is the closest side. Yeah. So that will also help. In addition to the signs, there's really no replacement for those signs. And here's a warning. HD will prolong your life. It replaces kidney function. However, is this going to alter the patient's prognosis? No, the patient still has no kidneys. So what's the ultimate cure? Replacement, yeah. So the patient will need a kidney transplant. Okay, so this will just prolong their life. Okay, that's all this is doing. Yes.
Did someone survive on the kidney?
Absolutely. All of us only need one.
So at what point, like, would they not need kidney transplant? Like, is that a possibility when one stops looking or?
Oh yeah, of course. Like my father-in-law, for instance, he basically has one kidney, and that one kidney is maybe 30%. Yeah, because he has uncontrolled diabetes, but that one still works. So he's not requiring dialysis. So if you want, you can give away your kidney, one kidney. So that's the problem. Not everybody is willing to do that. Oh, sad story. My father-in-law, his younger brother, who was a priest, had ESKD, and he begged his siblings to give him one. They had 7 siblings. Now, not one of the 6 offered him a kidney. He was a Catholic priest, yeah. Have you known bad Catholic priests? I mean, these guys
Usually that.
serve the church.
Do you?
Yes.
It's unethical, but doesn't mean,
Donation. I'm just,
yeah.
not trying to be silly, I'm just.
No.
Well, it's unethical. You should not, but I'm not saying it's not happening. So yeah, people have been paid. Of course, there's no receipt, like, here's the receipt. Yeah. It's all under the table, right? I mean, that's a fact. People pay for these things, right?
The black market for it.
Oh yeah, in Asia, there's a lot.
And
Anyway, so back here, so here are the complications, again, related to ESKD. So same thing, nothing new. On dialysis days, here are the complications. So in between days, because like I said, it's Monday, Wednesday, Friday, and then Tuesday, Wednesday, Thursday, no, Tuesday, Thursday, Saturdays. If the patient goes to a fiesta, celebrates in between, of course, they're going to have quicker accumulation of fluids, yeah? Because they eat, let's say, have you seen a party with no low salt party? Yeah, 2 gram sodium restriction party. There's no such thing, right? Is there a limit to like 1 liter fluid restriction for the drinks? Okay, so when the patient goes to a party, will they require just their usual 3 days? Of course, they will require an extra dialysis. And then when that happens, they will have to be admitted to the hospital. Okay, they'll have shortness of breath, hypotension, because we're removing large amounts of fluid here. Because unlike normal people like here, do we remove up to 4 liters of fluid from our body in a matter of 4 hours? No, we do that over several hours, right? We pee how long, how often? Every 6 hours typically, yeah? So our kidneys remove the water slowly over time. Hemodialysis, however, removes them, a lot of them, in a short period of time. So what will happen to blood volume? It will drop, blood pressure will therefore drop. So a frequent complication of hemodialysis is always hypotension. Muscle cramps because of the electrolyte imbalances. Remember, the dialyzer will not just remove fluid, they will remove electrolytes too. Or we have site-specific complications as well. You know, the needle comes out, we have bleeding all over, or clotting of the site, okay? Again, related to electrolyte imbalances, the patient may have abnormal heart rhythms, air embolism, again, caused by the site, or chest pain, or disequilibrium syndrome. These are the manifestations. Okay, again, this is a consequence of rapid fluid and electrolyte shifting. And these are manifestations of disequilibrium syndrome: headache, nausea, vomiting, restlessness, decreased level of consciousness, and seizures. Yes. What? No, meaning the needle came out. Yeah. Same thing as sodium, potassium. So we replace it. All right, so here you are now. So before sending the patient to dialysis, since you know that these are the complications, yeah? So you've got fluid overload, hypotension. So what are you gonna do? Remember what did we say? What are the patient's list of medications? If they have ESKD, what medications are be on their mark? Antihypertensives, yeah? Diuretics. So a lot of blood pressure medications in addition to the calcium and phosphorus supplements, in addition to the epoetin alpha. So therefore, since you know they'll have hypotension after dialysis, what are you going to do before sending them to dialysis? Are you going to give all those antihypertensives that are scheduled? Not all. So you're going to pick this one I'll give, this one I won't give. Again, I repeat, you know hypotension is likely to happen, correct? Right there, says so. So this is, right, so what are you going to do? Okay, so you're probably not going to give those medications because what will the dialyzer do to those drugs anyway? Most drugs are dialyzable, meaning whatever you give this patient will be removed by the dialyzer anyway. So are they useless? Are they basically useless? Yes. Because the dialyzer will just remove those drugs you just gave. Why would you bother to give them? Exceptions, of course, are, let's say the patient is diabetic. Will you therefore hold the insulin? Say the patient's diabetic. Patient is 200, 300. Okay, you still give the insulin. Okay, exception, of course, are the blood pressure medications. Probably not best to give them. However, if the patient's blood pressure is 224 over 125 before dialysis, should you give the antihypertensive? You have to. That's too high. Okay, yeah, because remember it takes up to 4 hours to remove fluid, so the dialyzer won't drop the blood pressure quickly enough. Okay. Some patients, not all, some patients may be ordered albumin after the hemodialysis session. Not everyone though. Okay, so the nephrologist will decide whether or not they will require albumin. Okay. It's not, again, it's not routine. So it really depends on the patient's labs. So, and also if this is the nurse's responsibility, so if the patient is on outpatient hemodialysis, same teaching will apply. So instructions will be, should the patients take their blood pressure medications? No, so same teaching. So here, clearly says antihypertensive therapy, often part of patients on dialysis. Okay, so they have to be taught on when and when not to take their medications. Okay, let's talk about diet. The rule is, of course, you restrict protein, electrolytes, and fluids, yeah, for patients with on hemodialysis. Okay. Now, some doctors may prescribe additional protein on dialysis days. Okay, because the hemodialysis procedure, the dialyzer will also remove proteins from the patient, okay, during dialysis day. So they may be allowed extra protein only on hemodialysis days. That makes sense? But is that our decision? No, that's the nephrologist's decision. Okay. And of course, this one, psychosocial. So just like anyone dealing with a chronic illness, now imagine yourself undergoing this 3 days a week. They're gonna put needles in your arm, sit there for 3 to 4 hours, and the cycle goes on next week and the week after, for the next few months, next few years, next few decades. And you're 18 years old. How are you gonna feel? Okay. So meet, of course, the patient, support them. Okay. This is not an easy life to live, right? So understand. So will they have manifestations of depression and also powerlessness? Okay, so they may be acting out. Okay, they'll cuss at you, for instance. They'll have a very, very bad attitude coming in for the dialysis session. Can you blame them? All right. So it's not you, okay? It's just how they deal with the situation. Okay? The powerlessness usually is manifested by anger, hostility, but it's nothing personal. So don't go saying, "Oh well, get out of here. We don't need the attitude." Okay, that's not how you deal with the situation. Okay, so just accept the behavior, right? So of course, when they get violent, that's a different story. But these behaviors are expected, okay, especially with their long term, plus the financial implications of these things, right? So again, not all people can hold a job, or here they may have even suicidal thoughts or plans. So here's your summary of your teaching. Now, the daily weight is very important for obvious reasons. What is the most accurate measure again of a patient's fluid status?
Every morning, same
Same.
machine.
That's not what I'm asking. I asked, what is the most accurate measure of someone's fluid status? Daily weight. Okay, there. Like I said, we will skip the kidney surgery. Let's do peritoneal dialysis. Age 1584. And we'll take a break. All right, so this is the other option. If the patient, let's say, usually patients who decide on this are patients who travel a lot, or those that do not like the idea of needles, right? So this is an option. Let me show you the picture. So here's what it looks like. Instead of a machine, we're still using osmosis here, we're still using filtration, and diffusion even, okay, but without a machine. So the idea is to use the peritoneal membrane as a semi-permeable membrane. It's like the filter. Okay? This is now the equivalent of the filter of the dialyzer. So the procedure entails that there will be a catheter implanted. So this catheter will be inserted by the physician on your abdominal wall into the peritoneum, and it stays in the abdominal cavity. Okay, just like the picture there on figure A. Figure B, that's the how it's anchored to the skin and the muscle. And then figure C is how the procedure works. So what they'll do is each session is called an exchange. An exchange takes about 2 to 2.5 hours, depending on the patient's tolerance. And the patient will be doing 5 or 6 exchanges per day, every day for the rest of their life. Okay, so let me explain again. So an exchange takes about 2 to 2.5 hours. And the patient will need to do 5 to 6 exchanges every day for the rest of their life. This will work, okay? So let's say you're in school, okay? So if I need peritoneal dialysis, what I'll do is I'll excuse myself, I'll go to the bathroom, I'll wash my hands, I'll connect a bag, I'll look for a hook in the bathroom. I'll connect the bag with the tubing, just like IV. Okay, so you'll spike it, prime it, connect it to your catheter. After wiping it with alcohol, open the tubing, and this bag is about 2 liters, 1 to 2 liters. So the fluid, typically 2 liters. The fluid will go into my peritoneum. So my belly will grow big because now I put 2 liters of fluid in there. That procedure takes about 10 minutes. So after 10 minutes, I come back to the classroom, I discard the bag, I sit here listening to class for about 2 hours. 2 hours later, I'll excuse myself. Professor, I need to go to the bathroom. I'll go. Connect it this time to another bag. This time I'll drain it. I'll drain the fluid out of my peritoneum. I'll move around so that all the fluid, because all the fluid will be everywhere here, right? Every space here will be filled with fluid. So I have to move around in order to expel that fluid into another bag. Now, the amount of fluid I discard, will it be the same as the amount of fluid I put in or more? What do you think? This is dialysis. This is peritoneal dialysis. Will there be more, the same, or less? There should be more because remember, this will use osmosis. So the bag is a hypertonic solution. So what will it do? It will pull water from my body, put it into the peritoneum. So it will draw water, excess, not only water, but electrolytes, BU and creatinine will also be drawn and eliminated, but at large amounts or small amounts at a time. Very small amounts at a time. That's why how many exchanges do I need to do per day? 5 to 6 a day. Then I'll do this again later. Right? I can do this, let's say we're going on vacation, right? We're going to Disney World, Florida. Okay, we're going to Florida. In between rides, I can do this. I can go to the bathroom, do the same thing. Then, of course, I'll maybe use a cane. I get a fast pass because I have a condition. I have a fast pass bracelet. Yeah, I'll skip the lines. Fast pass. Go on the ride. Whoop. Good. Go on a few rides. Then 2 hours later, I have my alarm. I'm gonna go back to the bathroom, drain it. And then put it on again. Go on more rides. 2 hours later, drain it again.
How is that?
Anywhere, kitchen, table, bathroom. Well, you wash your hands and then you wipe the catheter with alcohol. All right, so again, about 2.5 hours for each exchange. You do 5 to 6 exchanges a day. But you're not tied to a hemodialysis machine. You're not tied. You can leave, okay, whenever you want, because when you're on hemodialysis, you can't just go to another state. Okay, you can't just walk in. There's no walk-in hemodialysis center. You can't go, hey, you got a spot? I need the hemodialysis. You can't do that because you need a doctor's order, right? So if you want to travel, then you have to arrange that ahead of time, weeks at a time. Contact, maybe ask for a referral. Hey, doctor, I want to go to Tennessee. You know anybody there? So your nephrologist will say, okay, I know few people there. Yeah, we'll send this. When are you going? Okay, so we can do that, but it's a hassle, right? So therefore, you can't just leave at a moment's notice. Okay, so you'll have to arrange these things. Whereas if you're on peritoneal dialysis, you have control over your dialysis. You can do this yourself. I don't need a doctor. I don't need a nurse. I'm doing this myself. But you do have to travel with a lot of these bags because you need them. You need 5 or 6 of them every day. Understand? That's so who will benefit from this? So here's the advantages. Again, you can travel. You have control over everything. Yeah, this is an option for you. You don't want hemodialysis. And here's the disadvantage. You do have to do it 5 to 6 times a day, 7 days a week, 365 days a year. However, unlike hemodialysis, wherein your proteins are restricted, in peritoneal dialysis, because you tend to lose more proteins during this method, so there's no protein restriction in peritoneal dialysis. It's another plus. There's really no need to restrict you can have whatever proteins you want. Right?
So you said in the dialysis, you're gonna use
which one?
electrolyte.
Peritoneal or hemodialysis?
This one.
Same. You lose, but only little bits at a time though. Little bit at a time. That's why you need 5 to 6 exchanges because it can't remove as much as a hemodialysis machine.
I mean, the electrolyte, how you gonna get it since you, or you're not losing it?
Not much, because it's yeah, but you still lose it. Of course, this is dialysis. However, little bits at a time. Of course, you still need lab work, okay, every week, maybe. You still need lab work just to monitor is it working. And there are contraindications, of course, if you have adhesions or backache, because if you have chronic backache, can you carry 2 liters of fluid in your belly? Or maybe you have arthritis, or maybe you have some bowel disorders, let's say Crohn's disease or ulcerative colitis. It's probably not, or cancer. You can't have this method. But this is the setup. Okay, and I described to you the exchange. So an exchange has 3 phases. So when you put the fluid in, we call that inflow. The 2 hours that the fluid will stay in your belly is called the dwell time. So we have inflow, dwell time, and then outflow. Outflow, inflow about the same time, 10 minutes. Outflow may take a little bit longer because now you have to move around, make sure the fluids come out. The patient will also be on a prophylactic antibiotic just to prevent infection. Yeah, inflow, dwell time, and then outflow. So depending on the patient's labs, again, you may be given potassium chloride. But the patient can do this themselves. The very few rare times that I get patients who are on peritoneal dialysis, I don't even bother to do it. Because these patients are doing it. They're the experts. Okay? I'm not. I know how to do it, but who's the expert here? Who's the expert? The patient's the expert. They're doing this 5 to 6 times a day, every single day. I'm no expert. The patient is the expert. You understand? And I'll never pretend like, I'm the expert. I'm not. You are the expert. Okay, let's talk about complications. Most serious complication for this method is peritonitis. What is peritonitis? Infection of the peritoneum. Can this cause sepsis? Yes, no different than the hemodialysis catheter. Okay. But as long as the patient, of course, does correct aseptic technique, this shouldn't happen. Manifestations are diffuse abdominal pain, rebound tenderness, okay, hypotension. These are the manifestations. Or if the effluent is the fluid, what we call the fluid that comes out. If it looks cloudy, so just like urine, when your urine is cloudy, what does that mean? A UTI, yeah? Okay. So if it's cloudy, then probably has an infection. What if it's bloody?
It may not be a problem.
Well, minor bleeding is okay, especially if it's new. Okay, minor bleeding is okay. But if you see blood, like lots of it, oh, you may have perforated a bowel or something. Okay, or it could be trauma. What if it looks brown? That's poop. Yeah, that's feces. Okay, so that's reportable. So cloudy effluent, bloody effluent, brown effluent, all reportable. Okay. Leaking, this is possible during the first few, okay, because the catheter has just been put in. Here are restrictions. Do not bend, lift over 5 pounds, okay, for obvious reasons. You don't want to put strain on the abdomen. So here bleeding, I mentioned the bleeding, what's the cause and what to do. Okay, long-term complications, patient will have back pain, hernias, okay, because of you're always carrying so much water in your abdomen. So there could be umbilical hernias, okay, and the back pain, shortness of breath, okay, because your diaphragm's always pushing up, especially if the patient is obese to begin with. There's a automatic option for this one. So what I described to you was the continuous ambulatory peritoneal dialysis. No machine whatsoever required. For those patients who want this but are not ambulatory, we can do a peritoneal dialysis machine. It's a machine that will do the exchange for you. So you just connect your catheter to the tubing, and then the machine will do the exchange. Right? That's an option. We call that automated peritoneal dialysis. So some working people can still do this. I know someone. She's an executive, works Wall Street, comes home, hooks herself up at bedtime. So while she's sleeping, she's getting dialysis. Okay. And there's also a home hemodialysis machine now, which will be done daily as well. But that's not very popular because some patients are afraid how to use it because it involves needles as well. So this is the traditional, remember the example I gave you, like you right now, you're in class or you're going to Disney World. Okay, so this is CAPD, and there's this is the machine. Okay. We call the machine a cycler. Okay. And here's your summary for the teaching. Emphasize on the complications, okay? And of course, aseptic technique. Usually we don't worry about the aseptic technique because these patients have a lot to lose. So they are very, very careful. In my experience, they learn better than nursing students because you guys only talk about it like today, right? These patients have to deal with it. And who's gonna suffer if they don't do it correctly? They stand to lose a lot. Okay, they're the ones who's going to suffer peritonitis. They're the ones that are gonna go septic. They're the ones that are probably gonna die. Okay, they don't do it correctly. So the patient, their family members, very, very protective, very, very eager to learn, very, very strict on especially aseptic technique. All right. Any questions? Okay. Take a break.